Thanks so much for having me here today. So I'm going to be talking a bit about health spaces, and I'd like to start with a little bit of a personal story. So 2 years ago, I walked into the hospital for a routine 7-month ultrasound, and I didn't end up leaving for over 2 months. Until then, my pregnancy had gone smoothly, and my husband and I had had no surprises, apart from this moment when we went to our first checkup, and the doctor said, surprise, those are 2 heads, it's twins. But at that 32-week ultrasound, I was diagnosed with not only severe anemia, which meant that I would have to get a series of blood transfusions, but one of my daughter's umbilical cords was constricted, potentially fatal condition, they told me. So with nothing but the clothes on my back and my cell phone in my pocket, I was hospitalized on the spot, not knowing if I'd need to deliver that day or if I'd be able to hold out until the 34-week mark, which they informed me was the safe threshold for preemies. Over the next 2 months, I went through a spectrum of spaces, from exam rooms to the antenatal ward to hematology, labor and delivery, and eventually the OR and the NICU. I'm lucky enough to live in Boston, so the care was exceptional. It was fantastic. Yet, beyond being an architect who designs hospital spaces, I wasn't prepared for what it'd be like to live in one. In the antenatal ward, I wasn't allowed off the hallway, much less out of the building. And on the L&D floor, I didn't see another woman or another baby the entire time. In my room, there were 6 different types of trash cans. Was I going to make 6 different types of trash? This really stuck with me. What these spaces said to me was, this building is filled with people thinking about how to save lives. They're going to save your life and your baby's lives, but it's not really designed to address who you are or what you need. So in other words, this was not a home, and I felt institutionalized. I'm a healthcare architect and designer, so I think about this all the time. I'm a principal at Mass Design Group, which is a design collective that has worked on health facilities all over the world. And we've learned in our collective quest to design spaces that improve outcomes and reduce risk, that facilities sometimes forget that people have greater needs than to emerge from hospitals unscathed. Hospitals are the most institutional spaces that many of us will ever experience, but they're also the place for some of the most human and existential moments that define our lives: the birth of our children, the death of our parents, and sometimes a bad diagnosis. I saw this firsthand in Malawi. Malawi's rugged rural landscape makes it really difficult for pregnant women to get to health facilities, and this contributes to the country's high maternal infant mortality rate. So Mass was approached to create a center where women could come early, particularly high-risk women, to have safer births. And what they called it was a maternity waiting home. So at the time, the government facility was a barracks-like building with 36 women crowded into one hot, dark, stuffy room. And we quickly realized that maternity waiting homes, however, they're not really about shelter. The real opportunity is creating community spaces where women can begin a shared collective experience of motherhood and become invested in their health and their family's health. So our questions were, how can we design a maternity waiting home that encourages women to come and stay? How can it transform waiting into a productive and positive experience? And if it's supposed to be home, maternity waiting home, how can it reflect this idea of home and these women's own personal experiences and their needs? So we took our design cues from the villages around and the incredible social interactions that they support. We made our facility a village, a series of intimate sleeping rooms arrayed around a series of courtyards. We added some common spaces for cooking and incorporated bench seating outside so that women could gather and talk in the shade. And the benches would double as sleeping spaces for their family members at night who came along with them. After the building opened in 2015, we did an impact evaluation that got passed by the Ministry of Health, IRB, and we surveyed 600 women. We compared our maternity waiting village with a comparable government facility, and we're trying to understand the differences in the user experience. And this evaluation proved that the new design had much higher user satisfaction because it was not viewed as an institution. It was viewed as a community space for women to come and to give birth and to begin this life process and to support one another. So when I was in the hospital, the maternity waiting village was very present on my mind, partially because I was working on evaluation. I obviously could connect to the theme of maternity, but I also knew that maternity waiting homes weren't only applicable in places like Malawi. They were equally as relevant in places in the US, particularly rural areas. I'd seen an article in the New York Times about a prematernal home in Alaska that was lauded for addressing high maternal infant mortality in Native Alaskans by creating a place of community. And I was struck by a particular passage which echoed what we had learned in Malawi. It said, the results of the effort go beyond medicine. But later on, the article went on to describe that some of the women felt so homesick that they left despite the risks, in some cases giving birth along the side of a road. So when I look at the images of the spaces in the article, I asked myself, how would those women's experience have been different if the design were less institutional and more aligned with culture, place, and home? So a while later, it occurred to me that underneath it all, the antenatal ward that I was in was essentially, underneath all the bells and whistles and what it was called, it was essentially a waiting home. I was a high-risk mother in the final weeks of my pregnancy, and I needed to be close by a labor delivery unit. But other than needing to check my baby's heart rates a couple times a day, there wasn't really a reason that I needed to be in a medical space, per se. I was being taken care of, but the confinement weakened me physically, so much so that when I got home, I had trouble walking and trouble lifting the babies. And the isolation weakened me mentally. I was so bored out of my mind. I had my husband tote in my sewing machine, and when the nurses saw this, they said it was the craziest but most fun thing that they'd ever heard of. And I thought about it a little differently. Keeping my mind occupied and feeling productive so that I could stay there was contributing to the larger effort to save my daughter's life. When I was working on the evaluation and looking at the photos of the maternity waiting village, though, I felt a little strangely jealous. These women had so little, and their medical care was not going to even come close to mine. But they had community and they had purpose, whereas I was alone with my fabric until my husband could come by after work. The overall experience made me realize that if we are given a choice for a space that is a mere vessel of work to occur in versus a place of care and dignity, that we might choose the latter. These women in Alaska and Malawi made that choice, and I wonder what other ways are we making this choice to seek comfort and dignity no matter what the risks are. All the work that I've done with MASS has centered around the principle, like a core idea that spaces are never neutral. They either heal or they hurt. So kind of thinking on that a bit, I'd like to share today with you 3 ways that we have learned in our practice to elevate the conversation around healthcare spaces and shift the focus away from what architecture is to what it does. So first, as an architect, when you show up to a health facility, you're typically listed with a whole litany of problems. We're out of space. We only need 3 exam rooms to make it work. The outlets are all in the wrong places. People can sometimes assume that the role of design is just about maximizing efficiency, reducing mistakes, or minimizing adverse outcomes. But if we think that all that's needed to create spaces that matter to people are wood details and a view out a window, we know that those things are important, but it's really missing the point. Beginning with what's perceived as functional really results in reactive incremental fixes, Band-Aids, rather than transformative change that elevates care. In our work, we've found that the biggest thing that we can bring to the table, the most valuable role that we can play as designers, is not to show up with the aim of fixing visible problems that we already have identified from the outset, but with bold aspirations for what we're ultimately after, which some call a mission. What we mean by mission is a simple, legible, and transmissible idea for improving lives. We have built our firm around really hard questions. In Haiti, after the earthquake, we asked, how can we support our partner, the Haitian nonprofit healthcare provider Jaskio, to build a permanent, dignified facility for treating cholera, combined with a wastewater treatment system for breaking the cycle of groundwater infection. In Liberia, after the Ebola crisis, we asked, how could we help the Ministry of Health leverage the design of a new hospital to rebuild trust in the health system and prepare for the next epidemic? And in Montgomery, Alabama, just to mention one non-healthcare project, we recently completed the National Memorial to Peace and Justice in collaboration with the Equal Justice Initiative run by Brian Stevenson, which asks, how can a memorial dedicated to the victims of lynching in America heal our past and inspire reflection and change? As a young firm, wherever we work, whether it's in Malawi or Montgomery, Alabama, the way that we answer these questions and the way that we arrive at them in the first place is by understanding what values matter to people and to help organizations understand and articulate their philosophy of care and of healing and identify shared aspirations for what design should do. Deep contextual work and design research is usually time-consuming, it's expensive, and it sometimes can be uncomfortable. But without that investment, we may fail the very people that we're all seeking to serve. So we are often challenged about the impact of design because it's really hard to prove. In a world that is, we know is driven by bottom lines, without data, it can be really hard to convince the people with decision-making power to do better than the status quo. But beyond discrete, provable interventions, small things like, turning hand-washing sinks improves doctor hand-washing by X amount. We all know that there are a lot of things that matter to care up here that are really complex to measure. That doesn't mean that we shouldn't try. In 2016, we partnered with Atul Gawande's research organization, Ariadne Labs, to look closely at labor and delivery units. Ariadne was particularly interested in the problem of unnecessary C-sections, which shockingly range from 7 to 70%, depending on what facility a woman walks into when she's ready to give birth, independent of all of these things that you might think it would be associated with. So Ariadne had a hunch that the physical design of the units might play a role in kind of management and care practices, and they enlisted us to investigate. We together got a grant from the Robert Wood Johnson Foundation, and over the course of a year, we embarked on an exploratory study to wrestle with a really hard question. Can the design of a space affect C-section rates? So we did a literature review, and from that we found a lot of existing studies on birth spaces, but they typically looked pretty narrowly at patient experience in L&D rooms. We, however, were interested in the system forces that might affect clinical care, and so we looked into the birth unit as a whole. We visited and collected data on case studies across the US. It gave us a lot of rich insights about the care processes and allowed us to generate testable hypotheses that linked design measurements to C-section rates ultimately. So sorting our work into these 4 different categories, capacity, workload, motivation and accountability, and culture, this is what we found. The design of spaces can and does influence childbirth care. For example, facilities with the higher C-section rates tended to have greater room demand, which creates pressure on the unit, greater walking distances between spaces, which adds to staff workload, fewer collaborative spaces, which limits communication between staff, and also less patient-accessible space. And we know that women able to walk around are able to more naturally progress to natural labor. So these are just a few of the kind of design factors that we looked at. There were a whole list. But I think the bigger point is that even though it's difficult, more of us need to rigorously measure and evaluate to create change in spaces and institutions that have legacy and have bureaucracy. I guess in my experience, though, personally, a lot of time the results from these really rigorous studies end up kind of seeming like common sense. So why are institutions so insistent on seeing proof before doing what we know is right? I'm reminded of this quote from Malcolm Gladwell, which reminds us proof is important. It's very important, but we can't use it as an excuse not to do anything. The last lesson I'd like to share is that innovation doesn't come from only how we mitigate risks. It comes from how we amplify healing and amplify dignity. To this day, the image that I associate with my labor is the wall of 6 trash cans, which in the end, the nurses weren't even able to really explain, and they kind of started scratching their heads and like, I actually never noticed that. Facilities put systems and infrastructure into place to protect us, to create order. But when things get out of hand, when we get carried away, they create the opposite effect. It doesn't have to be this way. This resonates in particular with the project we're working on at the moment, the design of a behavioral health furniture line for Nemshov. And when we began looking into the current offerings that are out there on the market, behavioral health furniture is really defined only by what it prohibits. This is a pamphlet that we found. And it makes the point that to protect patients, behavioral health furniture is anti-everything. It's anti-ligature, which means you can't tie a noose around it and strangle yourself. It's anti-contraband, which means you can't hide dangerous objects in it. It's anti-movable, it's anti-throwable. But putting safety above everything else comes at a cost. At best, behavioral health products are disguised as something else, and at worst, they actually impede therapy. As part of our research project, we toured behavioral health facilities and we did over 50 interviews, and in every single conversation, the word prison, without our prompting, came up to describe these spaces. In fact, I don't know if everybody knows this, but some behavioral health furniture is actually the same as prison furniture. And there's a lot of evidence that shows why overly protective stuff sometimes has the reverse result. For example, patients get aggravated by furniture that's bolted to the floor, and they get aggravated by glass barriers around nurse stations. And for me, that message is, if you treat people like they're crazy, they're gonna act like they're crazy. There also is evidence for the reverse, that soft, warm, familiar surroundings calm people down and make them receptive to therapy exchanges. We are extremely respectful of the intense safety and durability requirements that these spaces require, and we will honor them. But beauty and dignity and comfort are not trade-offs against safety and cost and functionality. It's a false dichotomy. And if we are to move beyond institutional prison-like environments, we cannot start with this question of how we reduce risk or design for worst case scenarios, we have to instead ask how design can be restorative. So I wanted to show you that Mayans are here just fine. This is from last weekend. Although they did end up spending over a month and a half in the NICU. Because we had a happy ending, my memories of the hospital are not bad. It was institutional, but it was tolerable. But had things not been okay, the spaces would have really stuck in my mind as a jarring, undignified backdrop for bringing life into the world. I don't think any of us are here, any of us are in health, because we want to offer care in places that are institutional but tolerable. We make difficult choices every day with limited resources and this mindset of trade-offs, but we also have to ask, what is too much to sacrifice? To answer that, we have to begin with people and place and understanding that healthcare isn't a transaction, but an exchange, and it happens in our communities. The Maternity Waiting Village, our research with Ariadne, and the Behavioral Health Furniture Design Project, they might seem unrelated, but they're all fundamentally about leveraging design to improve lives. And as we all go back to our practices and our places of work, I'd like to ask each of you to think about what more these spaces can do. And if we could even make small changes, what would it take to make spaces that allow us to heal in the broadest sense of the word? So thanks so much for having me here, and I look forward to the conversation.
Thank you.